Good evening, everybody. Welcome to this group discussion. I'll be moderating this. And as you all know, a group discussion is just that. And I think it's important that all of us give our inputs. Uh, don't hesitate to say what you have to say, ask questions. And as I had shared the questions in the Sagar group, I trust that most of you would have read up about it. And what I'm going to do is address specific questions about an anastomotic leak and try and get evidence-based answers as well as the practical steps that we have to take. Uh, I believe in teaching that we don't teach anything purely for the sake of teaching, don't ask anything purely for the sake of asking questions, but it has to have direct clinical relevance. So you'll find that I will not be asking questions or giving answers on esoteric things. The most recent advances in research, even though I've read up about it, I would not be discussing those things because what I want this to be is a completely practical and clinical kind of take on the subject of anastomotic leak. By far, for a gastrointestinal surgeon, I think the anastomotic leak is the most humbling, perhaps, most distressing aspect of his or her work. And I dare say in the last 40 years, after a lot of work that has gone on in this area, I personally don't think any great advances have been made in terms of minimizing the anastomotic leak. It remains a challenge to the GI surgeon, and we will try to understand the basics of this phenomenon. And hopefully at the end of the hour, we are a little wiser about how we approach this problem. Okay. So when you say something about any subject at all, we start with the definition. What are we actually dealing with when we talk about anastomotic leak? All right, Praveen, what is your understanding of an anastomotic leak?
Sir, it is a leak of luminal contents from the surgical joint between two hollow viscera, sir.
All right. So what are the two components of it? You're quite right, actually. The two components are that you have made a joint with two hollow viscera in the GI tract, and that joint has opened up in some way. And because of that, the intraluminal contents have come out of the lumen, soiling the surrounding tissue in the extraluminal space. Okay, that's what we're talking about. So that kind of joint can be of any nature in between any two hollow organs or any two tubular structures in the GI tract. All right, so that's what we're going to talk about. But we must understand that most of our knowledge of anastomotic leaks in the GI tract has actually come from the colonic anastomosis, even though we have esophageal, biliary, pancreatic, gastric, jejunal, ileal, and colonic and rectal anastomosis. All these are the ones that most GI surgeons deal with. The maximum amount of work and the kind of research and the questions have been addressed, and whatever answers we're going to get eventually have come mostly, not all of it, but mostly from the colonic anastomosis. So to understand how anastomosis break and you get a leak, you must first understand how anastomosis heal. Nikita, tell me about the healing of an anastomosis.
Anastomosis usually heal like any other skin tissue, sir, in three phases.
Other tissue. Very right.
Being inflammatory phase, proliferative phase, and remodeling phase.
Yeah.
So initially, during the inflammatory phase, there would be hemostasis and inflammatory reaction, sir. It generally lasts for 1 to 4 days.
Yeah.
Then from 4 to 14 days, there will be proliferative phase in which collagen synthesis occurs.
Yeah.
And the remodeling phase, there would be the settling of the collagen, finally resulting in a strengthening of the anastomosis, sir.
All right. Very good. That's exactly what it is.
Usually ends by 1 month.
Yeah. So if you have different tissues what would be the difference in the healing of these different tissues? We have covered this in wound healing, but it's a nice recap in this situation as well. What is the difference in the healing rates of different tissues? In other words, would the skin, the time frame that you mentioned, would it be the same for all tissues, or is it going to be different?
It changes, sir. It varies from tissue to tissue.
Okay. In the GI tract, obviously skin will be different from the bowel. Bowel will be
Yes,
different
sir.
from bone, for example, even though they may all go through the same kind of basic steps. But what would be the difference? All right, we'll come to the chronology. We'll come to the chronology of the healing. But I have to the left of this, okay, the picture, I have diagrammatically represented the layers of the bowel. A is serosa, B is muscularis, C is submucosa, and D is the mucosa. In terms of anastomotic healing, what is importance? What is its importance? Vinod.
Hello.
Yeah, go on.
Sir, serosa is one of the main thing which is required for healing, because most what I read is if the serosa in the esophagus and the rectum which has no serosa, the chances of leak will be much more higher.
When you say it's one of the important, you're partially correct. When it's, if you say when it's very important, what is it important for?
Strength, sir?
No. Mistake. It is important for sealing. It's important for sealing the anastomosis. All right.
Yes.
So we come to this. What is the importance of submucosa?
This is the strongest of all, so we'll know.
It is the richest in collagen.
Yes.
It's the collagen that gives you the strength to the anastomosis. The proliferation and the remodeling that Nikita talked about occurs mostly in the collagen part, because that is what is the main strength giving layer of the bowel. So mucosa, submucosa is important for the strength. And the other important thing which can influence the healing is this, okay, a suture tract which goes from the mucosa onto the outside, onto the serosa, itself can be a facilitator for infection. All right, that's an important thing all of us must understand. That's one of the reasons the serosubmucosal suture, which excludes the mucosa in your suture, has taken existence, has come into existence. Okay, so it's important that you understand that the serosa is important for sealing, does not really give you strength. The submucosa gives you strength, and you must try and avoid a tract that would facilitate the passage of an intraluminal bacterium or the infection to reach the extra mural part of the gut. Ravi.
Sir, that is very extremely important point, importance of infection through the suture line. Also, more important is that mucosa is the most prone to ischemia. So if you take sutures through and through, and if the sutures are tight and subsequently when there is edema, if there is mucosal ischemia, then that will, very suboptimal mucosa will act like a nidus for infection, and that will then form the focus for anastomotic leak. So, which is why it is better to take the serosubmuscular suture, so submucosal suture rather.
Sanya, you have your hand up.
Sir, usually when we do a two-layer anastomosis, first layer would be a through and through suturing.
Yeah.
So, and then how do we avoid this forming a tract, like a suture tract that you're telling?
That is the point we're making, that unless you are very worried about hemostasis, it is always good to have a serosubmucosal suture and spare the mucosa. But in very vascular structures, like the stomach, for example, you have to do a through and through. But when you do that, you bury it with a second layer. And so
Okay, sir.
that part of it will be invaginated. And so you don't have a direct connection between the lumen and the mucosa to the extra serosal part of the gut. That is the reason you put a second layer. A single layer through and through, sometimes we do that in the esophagus, for example. You get away with it, but that is the least preferred method of anastomosis as far as
Okay.
a leak is concerned. Okay,
Okay.
right. So we talked about what causes healing. The other thing that we need to know, which is of more recent information that we have in the process of healing, the chronology differs. This is what I asked Nikita. And my next slide will tell you what the difference is, so we won't go into it, but please understand that we now know a lot. We used to talk about cytokines in terms of 2 or 3 things. Healing, these are chemical mediators of healing, of infection, of sepsis and things like that. We now know that there are specific named growth factors which have a direct influence on the healing. Okay, platelet-derived growth factor. And what is VEGF? I forget what it is. Anyway,
Vascular endothelial growth.
vascular endothelial, correct. Vascular endothelial growth factor. So these are the things that are now named things that have been described in wound healing. And one of the latest areas of research is something which is very interesting. Anything and everything in the human body, from healing to sepsis to neoplasm and a reaction to neoplasm, is now, and immunity and things like that are now attributed to the gut microbiome. Even though we don't know exactly what happens, even though clinically we have not reached a stage where we can manipulate the microbiome to improve the healing rates of an anastomosis. It is, I'm making a brief mention. There's a lot of literature written about it. I recommend that you go and read up about the gut microbiome and healing of the anastomosis. I promised you I'll be very clinical. As of now, there is no great clinical application of microbiome manipulation, but I suspect that will be the thing in the near future. So I would recommend that you guys go up and read about it. This is a picture that I think all of us must remember, all of us who deal with the GI tract. Okay, so you can look at it that in the gut itself, the way the bladder, the stomach heals, the colon heals is very different. And if you take the urinary bladder, for example, that is different. Skin, perhaps the least in terms of tensile strength. And so at 10 days, for example, you have 85%, nearly, maximum strength that you get is about 90, never get 100%. So within 10 days, the urinary bladder will have regained a lot of its tensile strength, 65% for the stomach and 45% for the colon. And this has a direct implication on your technique. What is the direct implication? Vinod.
Hello, sir.
What is the implication, direct implication of the knowledge that we get from this graphic? That at 10 days, the colon, for example, has 45% tensile strength.
Chance of leak compared to bladder, it will be more in the colon.
Probably, but what is more important as a surgeon? What decision that you make is impacted by this knowledge? Why do you need to know this?
So, chances will be much more. Before 10 days, and the sutures which we are using should have the strength.
Thank you. Sutures. Chances will not be more because it takes longer. You have to get a watertight anastomosis, watertight closure. But what the direct impact is, it tells you what suture to use. So your suture must hold the tissues together for a minimum period until it gets a 40 or 50% tensile strength. You understand that? So what we use is impacted by the sutures that we use is impacted by this knowledge. It's not just theory. Sanya, your hand is up.
So from this graph, all that we can understand is we get the tensile strength. The skin is at 120 days also it is still 20%, 25%,
Yeah,
if I'm not wrong. But why is
yes.
it flat, sir, which means the tensile strength remains at 25%? Or is there
The
a extension of the graph?
there's an extension of the graph because we know
Okay.
from other graphs that
Yes, sir.
the tensile strength of a skin wound will probably be 90 to 95% at the end of 9 to 12 months.
Yes, sir, yes.
All
So,
right.
but
And
is this
even
the same for others as well, like colon, stomach,
that
bladder? Everything shows a plateau here.
no. It's much faster for that's the whole purpose of this graph. That this, as I said, in the bladder, for example, in 10 days itself, it's 85%. I don't know when it reaches 85% in the colon, but it is much, much faster than the skin.
Okay,
Much
sir,
faster
okay.
than
So
the
there
skin.
is
So
an
that is
extension of the graph.
yeah, there is an extension of the graph, but this shows you only
Yes,
up to 120 days.
Yes, yes.
But
Okay.
that knowledge is important because we need to know what kind of sutures that we use. So you don't need an unabsorbable suture on the bowel at all. All right, something that lasts
Yes,
that lasts 3 weeks. That's what we normally use is good enough. And the
Yes,
reason
yes.
for that is that if you use an unabsorbable suture on the gut, the foreign body reaction will be higher.
Oh, yes,
And
sir.
so it's nice. You just have to give enough strength for the tissues to be held together in a watertight joint for perhaps 3 to 4 weeks. And that's all you need. That is the purpose of this. And so
Yes, sir.
that's why I put up this graph for us to understand that the technique that we use has a very sound theoretical basis of healing that we know about these tissues. Okay, let me just check the type of suture. Nikita has mentioned that. Yeah, okay. So why do anastomosis leak? Is the next question. We talk about it. We know what the basics of healing are. Why do you think they leak? Nikita.
There are two factors in this, sir. One from the side of technical error from the surgeon. Second thing is patient factor, sir.
Okay.
From it being his comorbidities to his personal habits, smoking, obesity,
Yeah.
other
All
small
right.
vessel diseases.
All right. So can you just name a few of the patient factors? And is it only the technique of the surgeon? I agree technique is important, but is it only the technique or is there something else that also impacts healing? I mean, or the lack of healing?
Technique as well as the equipment, sir.
Equipment?
Like the sutures, sutures or the staplers.
Okay.
And patient side, it is diabetes.
You're in the right track. Yeah.
Small vessel disease, sir, like ischemia, known case of some
Bowel
cardiac.
ischemia. Okay.
Yes, sir.
You can't stop at such a short list. Praveen, you want to add any more?
Malnutrition, sir.
Okay. Very good.
And,
Very good. Very good. Yeah.
And in inflammatory bowel disease patients, they'll be on immunosuppressions.
All right. Immunosuppression. Correct.
So it will affect the healing, sir.
Correct. Anything else?
And, if there is any previous radiation.
All right. Radiation is one. I agree. Look at the list. Okay. It's a huge list. And this is not just a list to ask questions and make you guys sweat in the exams. You just have to know that when you undertake surgery for anastomosis, you've got to give attention to all this. Okay, theoretically, I mean, you can't choose the age of your patient, but be aware that if somebody is older, there's a higher chance of a leak. Nutrition, I think, comes next. Hormones, even stress has been shown to have an effect. Diabetes, alcoholism, smoking is bad, obesity is bad, immunosuppression you mentioned, okay, steroids and chemotherapy. And the local factors, okay, ischemia is the main thing that you have to do because that's what we address when we we'll come to that later in the later part of the discussion. Tension, okay, this is the technique that you talk about. You can avoid tension in your technique. You must make sure that it is watertight. Foreign body, leaving a lot of foreign body behind, very thick, unabsorbable sutures. That's the one that I mentioned. Possibility of infection. So as I said, try and avoid taking this mucosa in your suture. Microbiome is always mentioned in all the lists, but what is its exact role? How can you manipulate it at a clinical level? As I mentioned, is not proven yet. Fecal contamination. We always tell you that when there is contamination of the peritoneal cavity, fecal contamination, or even purulent contamination, don't do an anastomosis because your sutures will not heal, they fall apart. And the improper technique is a combination of these two. Okay, causing ischemia by very tight sutures, not avoiding tension, and not ensuring a watertight joint. Okay, and it doesn't stop here. There are other factors also that you have to know, and a lot of it is repetition here. Okay, the only thing that is not mentioned in the previous list is the high ASA score, increased comorbidity. But please understand, in addition to the things that we mentioned, okay, intraoperatively, these are very important for us to know. Apart from the technique and ischemia and all that, vascularity is ischemia, that is a repetition, but the level of anastomosis is important. So, Vinod, what do we mean by this level of anastomosis in the GI tract?
If it is a small bowel, the chances the healing will be good. As it goes closer to the rectum, the chances of leak will be much higher.
Very good. We'll learn a little more about it as we go along. But yes, that's what it means. If it's an esophageal anastomosis, it has a degree of risk. If it is a pancreatic anastomosis, a different degree. If it's small bowel, it's different. Large bowel, it's different. And in the large bowel, a colocolic and a colorectal will have a different kind of healing rates or leak rates. And operative time being very long is again a risk factor. Blood loss, because it can indirectly affect the vascularity. If the patient is hypotensive on the table or in the post-op phase, you mentioned here, if you have to use inotropes for a prolonged period of time in your post-op phase, then you're in trouble. Okay, that is something that you have to understand. Delayed diet. And again, as I said, all these things are the microbiome is mentioned. But I've really looked at the literature. I'm sure many of you have. Exactly how it impacts is not known. It is important to have early feeding. Otherwise, you will have a lot of factors, including gut hormones and motility, which can impact on the leak rates. Blood transfusion, how do you think that that negatively impacts the healing? Praveen.
I don't know exactly, sir.
You don't know. Nikita.
Would it cause some coagulopathy, sir? I mean,
No, coagulopathy is not the answer. We keep telling you avoid a blood transfusion in the pre-op phase. Okay, don't give blood because it causes something. And I'll give you a more direct hint. People say, okay, when you're doing a renal transplantation, give blood transfusion. It actually has a positive impact on the survival of the transplant. Why do we do that? Immunosuppression. Okay, blood transfusion causes immunosuppression. And we learned in the previous discussion that immunosuppression has a negative effect on healing rates, increased leak rates. Okay, I will stop here and invite comments from the teachers. I've talked about vascularity here. Okay, but before I go to that, anything so far? Because in vascularity, I have a thing or two to say. Niranjan, any comments?
Sir, nothing, sir.
Nishant?
Sir, nothing.
Okay. All right. Ravi, Atmaram, anything to say?
So vascularity, I think, are we going to elaborate on how
We are going to elaborate. That's why I just took a little break to talk about that. Yeah. Okay. So in terms of vascularity, what is it that a surgeon can do to ensure that there is good vascularity of the joint that we're going to make? Sanya, let me throw that at you.
The first is to ensure the edges that we are approximating do have some kind, like a little ooze, or don't look pale, sir. And the tissue that we are approximating should not have purplish hue or discoloration, indicating that that won't be viable.
Okay.
Third thing we can do is we need to see the arcade that is supplying that part of the bubble
Very good.
and make sure that we don't ligate that or peel it off.
Yeah. How do you ensure that anatomically, particularly in the small bowel and the large bowel,
Then
that
we
you
can, like the transillumination against the light, we can see the arcade and the vessels that are going into the small bowel, sir.
so
So
in this
depending on
in the
our
small
plan-
bowel, which is the level of the arcade that you have to maintain from the main vessel that comes through the mesentery? You will have 3 levels of arcades.
Yes, sir.
That's
Yes,
what you
sir.
look at. That's what you look at
Yes,
when
sir.
you transilluminate. Which is the level of the arcade that you can comfortably sacrifice or tie off?
The most distal one. Sir.
First one, the one that is most proximal to the
bowel.
gut. Okay.
Gut, yes.
Yeah, the mesenteric arcade, which is the first one from the edge of the bowel. Can the second one be can that be sacrificed or
If
not
we
at all?
Can be, sir, if there are other vessels that you can see arising.
Correct.
Like
That is, yeah, that's correct. So second vessel, you may have to sometimes to get the length and things like that, but you have to be very careful about it. The first one that is closest to the edge of the bowel that you can very comfortably sacrifice when you do. So in the large bowel, what is it that you're looking at? See, this is about small bowel.
Yes, a large bowel is usually, it has a lot of anastomosis, and because of the arc that it forms, it will have good vascularity.
No, let me
So
let me rephrase, let me rephrase my question. Where do you and how do you decide the resection margin? Suppose you're taking out a neoplasm, for example.
Yes, sir.
The standard teaching is that you must have a 5 centimeter clearance from the 2 edges, 5 centimeters proximal to the proximal edge and 5 centimeters distal to the distal edge of a tumor. But as you know, in the large bowel, we take out a lot more, much more than 5 centimeters. What decides that? What decides where you do the cut?
So the area that is supplied by the major branch that is coming through.
Correct. So you have to know which branch of either the SMA on the right colon or the IMA in the left colon, which branch you are sacrificing, and how do you decide which one you're sacrificing?
So that depends on the site that we are looking into.
Correct.
Ileum, and if the terminal ileum and the cecum it is, then we'll be looking into the ileocolic and also the descending branch of right colic.
No, but what, as I said, what actually decides where you take the vessel, ileocolic or right colic or whatever, middle colic?
The root only.
Why the root? That's what I'm asking. I know you
The
take
lymphatic,
the lymphatics. Correct. That is what the students must understand. Okay, Nikita, Vinod, all of you understand that we take out a lot more of the bowel than is required oncologically as far as the distance from the tumor is concerned, because we are aiming at lymph nodal clearance. And the lymph node we must be the most proximal, which is at the root of the vessel. So when you take the vessel at the root, whatever branch of the vessel is, or the SMA or the IMA, that much of the length will be devascularized. That's why you have to take out a much longer length, which essentially I'm coming to the point that you must know which branch supplies which area. And so that is where you decide if you're retaining the left colic artery, for example, you can take the descending colon, retain the descending colon. If you're taking the left colic artery, for example, if you're actually taking it, not preserving it, then you're only looking at the vascular supply of the left branch of the middle colic. So you'll probably have to take this splenic flexure for safety. So that kind of anatomical knowledge the surgeon must have before he decides where he takes it. And then you come to the macroscopic local factors, as you rightly said. The bowel must be looking pink. It should not be bluish. And when the cut edges must bleed and must ooze some blood. But how accurate or inaccurate is this clinical assessment? All right, let me put it this way. Is there something else that will help us decide the vascularity better than just these things that we listed now?
Handle Doppler, sir?
Doppler? Much more than Doppler?
Indocyanine.
ICG. Okay. ICG is something that has come
Okay.
into way. Okay. And so you find that nowadays it's becoming more and more popular. But ICG is not a panacea, it's not magic. Okay. It does help you. Suppose your naked eye assessment tells you that vascularity is good. If you do an ECG in about 8 to 15% of cases, it may tell you that it is not as good as you think it is. And so you may have to revise your level of resection. Okay, but that is something that has a practical significance. Now, particularly in the colonic anastomosis, it is something that one could consider doing. Okay,
So
that's an.
What about in infective conditions or in other than neoplastic conditions when we are doing a resection?
Yeah.
At that time do we have to go to the root, or we
Not
can
at
just
all.
be as proximal as
Not
possible?
at all. Not at all. If you're doing a resection for inflammatory bowel disease, for example, you
Yes,
keep
sir.
close to the gut.
Sure.
And so
Yes,
there is no question of going to the root or taking
Root.
long lengths. You can take out whatever little
Yes, sir.
segment that you want.
Yes.
Okay.
Okay.
Yeah. Any other comments so far? Okay. So we now have an interesting thing about so many other myths that we have, which many surgeons talk about and actually carry on in their practice, but which really don't have any effect on the actual incidence of the anastomotic leak. Can you think of a few of these situations? Praveen?
Can you repeat one, sir? I could not get it.
Sorry?
I could not get the question, sir. Can you
Okay.
ask
Yeah,
once
there are several things that we do when we do an anastomosis with a feeling that may have a positive effect on the leak rates, in the sense that the leak rates will be lower. It's several things that we do as surgeons, but which actually is not supported by evidence. Let me make it even more simple for you. What are the things that you do before you do an anastomosis? Let's look at colonic anastomosis.
Sir, basically the type of suturing, sir.
Actually, even
And,
before we do the anastomosis, we do some. See, Nishant has given the answer. Nikita had
bowel
given it as well.
preparation.
Okay, bowel preparation is one. Okay, type of suture, continuous or intermittent. Okay, that's one of them. All right, anything else that you can think of? Drains. Drains, very good. What else? Okay, drains. Drains have absolutely no effect on anastomosis or its healing. Okay, I also maintain that some people say, even though it may not have any effect on the healing or the leakage from anastomosis, they say you'll detect it earlier.
No.
Even that is not correct, because the drain may be blocked. It may not come out at all. So a clinical assessment is much more important than having a drain. Similarly, a diverting stoma. People say that you should have a diverting stoma because that may actually reduce your leak rates. It does not reduce the leak rates, that is for sure. But the soiling that may occur if you have a leak may be limited because you have a proximal diverting stoma. Okay, that is all there is to it. And so a stoma is really not a must. But if you have a low anterior resection and you're concerned that if it leaks that there may be a lot of soiling there, you really are not wrong in giving a stoma. But please don't have the idea that the presence of a stoma will reduce the leak rates. In bowel preparation doesn't have an effect. Now many people have stopped doing a proper mechanical bowel preparation that we all routinely do. I haven't made it a routine in my practice, to be honest. But yeah, I might change my mind and say, okay, don't worry about the bowel preparation. Again, the reason I do it is not because I think it will reduce my leak rates, but again, soiling at surgery will be much less if you have an inadvertent damage to the bowel, for example. Tomorrow, we are doing a pelvic operation for an extensive cancer that we have. And so if you're operating in that area, it's good that your bowel is clean. So even if you have a little damage to the bowel, then you have better control on it. So in those situations, I think a bowel preparation is justified, but please do not think that that will reduce the leak rates. That's the point I'm making here. Go on.
I think I was a strong proponent. Even in the Association of Coloproctology, there was a debate between bowel preparation or not, and I spoke against bowel preparation. But the recent evidence suggests that for majority of colonic resections, what you said is right. But for low anterior and anterior resection, it may be better to have bowel preparation, because even if you do a fecal, for diverting ileostomy, loop ileostomy, the fecal, fecal stream that is there in the redundant colon will drive the sepsis. Yeah,
Correct.
will drive the sepsis. And see, the major issue up in, as you said rightly, is in the low anterior and anterior sections.
Yeah.
If there is a leak, it will cause pelvic sepsis and subsequent fibrosis. Even if the patient comes through that easily, the functionality of the bowel of a fibrosed colorectal anastomosis is, will give them a very bad quality of life, because so that is another argument against, not, so as you said, the the diverting stomas may not help in preventing anastomotic leak, but it may reduce the effects of
effects of soiling. Yeah, that is the thing. So honestly, the final word is not said. I've been reading about this debate for the last 30 years, and still there is no very clear idea. But I think either you prepare or not prepare the bowel is left to a surgeon's choice. But I do believe that preparation will probably help you operate in a cleaner field, particularly in the technically different operations. Abdul had raised a question with blood transfusion. Hypocalcemia, will it have an effect on anastomotic healing? No, the answer is no. Nishant talks about controlled fistula with a drain. It is very debatable, Nishant, because if you have a tube that gets blocked, which it can do in case of solid fecal content, then it won't work, and you won't have any drainage, and so the intraperitoneal soiling will continue. And if you don't have a drain and you have liquid content, which is easily drainable, a quick ultrasound or CT guided drainage will do the same effect as a drain. So just to facilitate a controlled fistula, I do not think need for a drain is justified. Okay, that's the way I look at it. So what is the extent of the problem? I told you that different.
One point, sir.
Yeah.
Sorry. See, the mechanical bowel preparation is likened to a man running a marathon. So if you are running a marathon, you want to be well hydrated, well nourished the day before you actually run the marathon. So if you are giving bowel preparation and starving this patient, because most of the time that is what they do, and you're allowed only to take liquids, and even that is not very rich in nutrition, and then they use the toilet, and if you don't start the bowel preparation early, they are up all night and they have no sleep and they are not well rested. So you don't want a person who is going through marathon. You can actually understand, if you don't run a marathon, nothing is lost. But this man is fighting for his life. So you want a patient to be well rested, well prepared, well nourished, and well hydrated. So I think if you are giving the bowel preparation, you have to ensure that the timing is correct and the patients are well hydrated in addition to that, and also nourishment also needs to be taken care of.
Point well taken. Point well taken. So as a corollary to that, all my bowel preparations take place the previous day in the afternoon. All the purging is over before 6 o'clock, and we'll start a drip early in the morning and keep them well hydrated before they come to the OT. And in the operation theater, we clearly tell the anesthetist that the patient has had a bowel preparation and to push the fluids. And so the patient is well hydrated. Sanya, you had your hand up?
Yes, so the same question I had, if you're doing a bowel preparation in general, what are the protocols you follow? Like
Yeah.
you said, you have made it a
I've just
routine and
answered that. Yeah, yeah. Okay,
yes, yes.
right.
And also
So,
one more question I had,
yeah.
sir. Is there like drains are not at all required in any type of anastomosis do, or do we have certain anastomosis that we do? Like for example, if it is a perforation peritonitis causing a lot of soiling already. So
Good
in that case,
question.
do we
Good question. So what I'm saying is that you do not need a drain with the intent of reducing the anastomotic leak.
Yeah.
That's the first statement. Second statement, wherever else you would like to put a drain, where you expect a degree of fluid collection in defined spaces like the pelvis, the paracolic gutter, the subdiaphragmatic space, or the subhepatic space, not in the general peritoneal cavity. If you have these defined spaces and if you had an extensive dissection, you would definitely expect a lot of peritoneal outpouring because of the dissection itself. In those situations, certainly put a drain, but try and take it out as soon as you can. Nishant, your hand is up.
Sir, regarding the
Voice is breaking, Nishant. Nishant, your voice is breaking. Nishant, your voice is breaking.
Sir, diverting stoma in patients or what?
Your voice is breaking for some strange reason. Perhaps you can put your point in the chat box and I'll take it from there. Okay, Ravi.
Sanya, you asked a question about perforation peritonitis. Then we
Yes,
are
sir.
now talking about anastomosis and anastomotic leak. You are probably
Yes,
well
sir.
advised not to do an anastomosis in that situation anyway. So you are going to bring out a stoma and then you put a drain, as the sir said, in the set
Yes,
spaces
yes,
like
yes,
pelvis or paracolic gutter subphrenic space.
yes.
Okay, Abdul, you have raised your hand.
Yes, sir. Regarding the feeding, sir.
Yeah.
Does feeding cause more leaks, sir?
Feeding will actually improve the healing.
Okay, what
Okay.
type of it? Clear liquids, sir? Clear liquids
Yeah, I mean,
improve?
as you know, feeding has 2 or 3 important salutary effects. Okay, one of them is the improved motility, which itself might help in the healing, and the distension that occurs with ileus is less, and so regaining motility is important. There has been a mechanism for enteral hormones. There are local hormones which are better produced when somebody is fed rather than when somebody is starving. And third, it improves the quality of the microbiome, kind of organisms that you have inside the gut. So for these 3 reasons, nowadays, unlike the olden days, early feeding is recommended. Of course, one of the minor things is the reduction in the presence of A calculus, in the incidence of A calculus cholecystitis. So these are the reasons why people promote early feeding. And the early feeding has to be with a low residue diet. There has to be some carbohydrate, there has to be some protein, there has to be some fat, but a low residue diet is what is recommended. Ravi, your hand is up.
Yeah, one more addition to the points that you made is the improvement in mucosal blood flow with feeding, which again is an extremely important thing. That is, I think, a significant point in advocating early feeding.
Yeah, true. Nishant, your point about diverting stoma in irradiated bowel and neoadjuvant treatment. No, diverting stoma will not help in either of these. All right, in terms of leak rates. But then the same point that we made, if you think that your anastomosis is tenuous and you may have a high leak rate, perhaps because it is previously irradiated, then to reduce the ill effects of a leak, you're definitely advised to have a proximal diverting stoma. Okay, this is the point we make. We're not saying you should not do a proximal diverting stoma, but that's not to improve the rates of healing. That is all that I'm trying to say. So what is the extent of the problem? Okay, I won't ask these questions, but give you the answers according to the literature. All right, the data is very variable. Please note here that the range is really very big. Sometimes it says 5 to 40% or something like that. It's a huge range. So depending on the series that you see, but within that, we have to have some ballpark figures, particularly to quote to our patients when we do this anastomosis. So in that, the ballpark figures that I can talk about, for esophageal, say it's about 10%, gastrojejunal, very low, 1 to 2%. If you do a GJ, it hardly ever leaks. Pancreatic, 20%, which is not a small amount. Small intestine, again, low, 2 to 3%. Colorectal can be anywhere between 5 and 20%. I usually quote 5 to 8% as colorectal leak rate. And for pancreatic leaks, I always quote about 10 to 15%. Not more than that, because many other series have shown this to be a little less than 20% also. But these are the kind of ballpark figures we must have in mind. We know your hand is up.
Sir, regarding feeding, sir,
Yeah.
depending on the site of anastomosis, will you start the feeding, sir? Or,
Obviously, I obviously didn't go into all this in detail. So if somebody has an esophageal anastomosis, you're not going to feed them straight away. Okay. But anything which is beyond the stomach, most of the things that I quoted refer to small bowel and large bowel anastomosis. Okay. Yeah.
and you start a soft tissue.
And if you have a tube beyond an esophageal anastomosis, which is very common, or a tube even beyond a gastrojejunal anastomosis into the jejunum, for example, you can start feeding them the very next day. You understand?
Yes, sir.
Okay.
What about if it is a colorectal anastomosis?
Yeah, feed them the next day. That is, you have heard about ERAS now, right?
Yes, sir. Yes.
Yeah. So if you look at the ERAS protocol, that's what they say. Early feeding is one of the main pillars of an ERAS protocol. Ravi, your hand was up.
Vinod, to answer your question, sir has already answered it. The ERAS protocol has been tested in all the subspecialties: gastroesophageal, hepatobiliary, pancreatic, colorectal, and everything, and urologic as well, and gynecologic. And in all the fields, it has been proven to be, good. So, which means you start early feeding in almost all the anastomosis that you make.
Okay, the reason I mentioned about the tube beyond the anastomosis in proximal GI is because of the rates of ileus. We have mentioned that no ileus in the small bowel. Next is stomach, next to recover is stomach, and the last to recover is the colon. So you can feed into the small bowel from day one of surgery, from the post-op day one, the day after surgery. So if you have an esophagogastric anastomosis or esophagojejunal after a total gastrectomy, for example, I normally leave a tube across the anastomosis and start feeding them into the jejunum. Similarly, GJ, if you feed somebody without a tube beyond the GJ, then they have gastric paresis, gastroparesis is there. There is an ileus. So they'll get gastric distension, which makes them very uncomfortable. They may aspirate, they may vomit. So I usually have a tube across the gastrojejunal anastomosis and then start feeding them the next day. So putting food on day one into a small bowel is the recommended procedure presently. Okay. The next thing we have to understand is the difference between radiological and clinical leak. Okay. What do you understand by that, Nikita? Okay. She's
the way of diagnosis, sir.
You want to go to an emergency? You go ahead. No
I was
problem.
about to leave, sir.
Sorry.
I'll answer this and leave, sir.
All right.
I'll answer it and leave, sir.
All right. Go ahead.
Clinical leak is from the clinical signs. If you are able to diagnose that there is a leak,
yeah,
that would be clinical. But if we are suspecting a leak and we do a CT or a gastrographin study and then we diagnose it, it would be a radiological leak, sir.
Why would you suspect a leak when there is no clinical symptoms?
When the patient is not improving.
That means there's a clinical leak.
Yeah.
So what the context where you do a radiology is in studies normally. You understand? Patient is fine,
Sir.
but there are many studies where they have done radiology. Okay. And they have found that the clinical leak is nearly twice as, sorry, the radiological leak is nearly twice as common as a clinical leak. You understand?
Yes, sir.
Are you with
Yes,
it?
sir.
Yeah. So if you know, when suppose even in bariatric surgery, you're talking about it. We have done it in low rectal anastomosis. So routinely people would get a contrast enhanced CT or in the earlier days, a gastrograph in barium swallow or a barium enema. And they found that the radiological leak was much higher. The patient was fine. So the point that I'm making is that when you're actually treating a patient, you will have to go more by the clinical signs and symptoms than by radiology, even though radiology is a very good tool to diagnose leak when you suspect it on clinical grounds. Okay, you understand that? All right, Ravi, you have anything
sir.
to add? Yeah.
Yes, sir. I think radiological leak, there is quote anywhere even up to 40 to 42%. But the clinical relevance is only, as you said, depends on different organs. Maybe the colorectal is about 10 to 12%, and pancreas is maybe about 15 to 20%. So your presumption that it is about double is correct. So it's about 40 to 42% if you image all the people who have undergone anastomosis.
Yeah. All right. So the important thing is, now we'll come to the diagnosis of anastomotic leak and the treatment later. I didn't realize that we are going on for so long, it's nearly 5 minutes to 10. Should we do another class or continue with this quickly? What do you say, Ravi?
How long will it take? 10, 15 minutes? I think we'll finish
another
it.
20 minutes.
Yeah, we'll finish it, I think.
Can finish it, yeah. So I'll also go a little faster. What we do when you suspect a clinical leak depends on our understanding of the consequences of a leak. So Vinod, can you tell me what the consequences are?
Sir, symptoms like peritonitis and abdominal distension.
No, I'm looking at the broader pictures of what happens to the patient's life, his condition or whatever. We'll come to the clinical symptoms later once there's a leak.
Morbidity will increase.
Okay, in all the cases, all the time?
No, sir. If the symptoms are there, then.
So what are just list the problems that the patient can have. I just mentioned about a radiological leak in a patient who has no symptoms. So the first item on this list would be an asymptomatic leak.
Yes.
Consequence, nothing.
Nothing.
Okay, it's a range of consequences. That's what I'm trying to say. So I started you off on that list. So completely asymptomatic. Okay, what comes next?
Mild, moderate.
All right. Mild, moderate, severe is very, very rare. Anyway, you may have mild symptoms, but then you can have an intra-abdominal abscess. Okay, what can happen next?
Peritonitis.
Yeah, there's a general peritonitis. If it is not restricted to one area, you get a general peritonitis, or this abscess may burst through the skin and you get an intracutaneous fistula. If it doesn't burst through the skin but bursts into some other organ, you can have a coloileal or colojejunal fistula, cologastric, colovesical. Okay, it can open into anything, and you get a viscous to viscous fistula, bowel to viscous fistula, and of course, fulminant sepsis.
And death.
Okay, so this is a range. And so what you do with patients with a suspected clinical leak is very variable. You find that most of us, when we start off our careers, the moment somebody is a little unwell, okay, we all suspect a leak, all of us. But the way a consultant with experience responds and the way a registrar responds is widely different. A registrar calls the consultant with panic most of the time. And he always feels we should go in and do something about it. But you'll find that because we understand that there's a range of these consequences, we go a lot with clinical evaluation of a suspected sepsis. And because of this, there's a broad grading that has been described. And that is what has been very well done. You know, it's Rabari in 2010 described this. There may be no change in the management. It may be so mild. You may have an active intervention. I'll tell you what those interventions are, but may not need a reoperation. Some of them need a reoperation and sometimes very urgently. So there is a range of reaction, a range of consequences, and a range of reaction to a suspected leak. Ravi?
So this you said the Rabari classification.
Yeah.
Is it different to the Clavian Dindo? Because Clavian Dindo also goes
It
around.
is a lot more generic. Clavian Dindo is a lot more generic.
So this is
this
specific
is
for anastomosis.
Correct.
Okay.
Specific for anastomosis. That's the only difference. Yeah. Yeah. Okay. So we now come to the next question. How do you diagnose a leak? Quickly, Praveen.
Sir, intraoperatively, we'll be doing by air leak testing, sir.
Okay.
And if possible, direct endoscopic visualization.
Intraoperatively.
Yes, sir.
How
For
many times has
esophageal
your...
gas.
Okay. All right.
And
yeah.
in
I'm more interested.
in
I'm more
visualization.
Indocyanine for a leak. No.
Through NIR imaging.
For a leak.
That is
Yes,
only
sir.
to assess vascularity, man.
It is to assess vascularity, not for a leak. What you use for leak is a water soluble dye. But let us come to you're talking about the intraoperative. I think for all practical purposes, we use definitely the air leak test, and if that is if the integrity of the anastomosis is maintained, you go ahead and close the patient. In the post-op phase, what are the things that you look at? Okay, because of lack of time, we are going very slow. So it's a range of things that you have to look at. It's not, again, just one aspect of the patient. Clinical symptoms are extremely important. Okay, vitals are important. Pulse, BP, temperature, tachypnea, the toxic look, any discharge from, I got this patient who had an appendicectomy 4 days previously. They had left a drain like this, and you can see fecal matter coming through the drain and from the wound as well. Okay, so discharge, laboratory investigations, high WBC, lactate and procalcitonin are the sepsis markers. Radiology, contrast enhanced CT is one of the hallmarks or the basic pillars of diagnosis of a bowel leak or an anastomotic leak. Contrast radiographs were done earlier. Ultrasound can be done, but it doesn't tell you what the leak is, but it will tell you if there is a localized collection, and you can do an aspiration before drainage of a localized collection and see if there is any fecal contamination. Endoscopy to be done with care, but it can be done. There is no absolute contraindication for endoscopy, even with a 3-4 day old anastomosis, but has to be done with minimal insufflation. You should not stretch the bowel with a big time insufflation. And you always have a recourse in a patient who is very ill to diagnostic laparoscopy and laparotomy straight away to see what needs to be done. But this is the last resort. Don't jump into a laparoscopy or a laparotomy. Okay, so that is the sort of the whole list of things that you can do. But how do you select which one you do? I already mentioned that clinical assessment is important. In the clinical assessment, what do you think is the most important part? Abdul, can you tell me?
The tachycardia, the pulse rate.
All right.
And then
I've given you the answer on the table.
Urine
okay.
output, yes.
Yeah. Vitals are important, but the most important is what I put in bold. Organ dysfunction. You find that the patient is hypoxic, patient has diminishing urine output. These are the two common things that you see. If that happens, then you have to jump in and take quick action, not necessarily laparotomy, but taken in quick action. All right. So you also, to some extent, depend on investigations, particularly, as I said, a contrast, water-soluble contrast enhanced CT, and you can use the ultrasound or CT to look at collections. If you have a collection, you have one more, both diagnostic and therapeutic method, which is an ultrasound guided aspiration. And if it is, feculent or its bowel contents are infected, you can put a drain as well. That's how you decide. But the main thing that you go by is the toxemia and organ dysfunction. There is a degree of subjectivity in that, but you have to basically depend on these two parameters. Okay, anything to add, Ravi?
I think you summed it up well, sir. I think how does the patient look and feel?
Yeah.
When ask the patient how he feels, and then you at the end of from the end of the bed see if the patient is mildly hypoxic and breathing difficulty and not looking good. I think you should be very, very post-operative assessment of a abdomen is probably the most difficult challenge any surgeon faces. So which is
Very
why
true.
it is very difficult.
Niranjan, you have anything to add? Okay. So, as I said, the range is very, very wide about the choices that you have. But can you list some of the conservative measures that we can do? Can we ask Dilip from Sahyadri? Dilip, tell us what is it that you can do, conservative measures? Not there? All right. Vinod.
Sir, we'll prophylactically we'll start the antibiotics, sir. And
It won't
if it
be
is a collection,
prophylactic, no? How
Prophylactic.
can you call it prophylactic? We are treating the leak now.
yes, sir, we'll start the antibiotics.
Start the antibiotic. So you must be careful about the words you use. Okay.
And if the collections are there, we keep dry ultrasound guided drains.
Okay.
And if the leak is much more, you can go for a diversions.
I'm talking about conservative measures, and you are just going wild.
Okay.
Understand, step by step. You are a registrar somewhere, you're a young consultant, you have a patient with a leak on your hand. So when there's a leak, give bowel rest. Don't start feeding them, okay, until you know where the leak is and all that. It's just initial. First thing is bowel rest. Antibiotics, you hit them hard and hit them wide, which means you use a wide spectrum antibiotic. Give them good doses, intravenous doses. You must have nutrition and fluid support. Very important. If necessary, start a TPN. But if you have other modes of using the gut, try to use the gut. It's always better than using a TPN. And what is very important is that the patient can become ill and go into organ failure anytime. So they have to be monitored very carefully, if necessary, in an ICU. Or if you have good supporting care in the ward, you can definitely monitor them in the ward. But it is important to be monitoring them very carefully, both clinically and biochemically. That's important. All right. So the next step from just conservative treatment, bowel rest and the things that I listed, is to have minimally invasive methods. What are the things that we can think of in a minimally invasive fashion other than a laparoscopy or a laparotomy?
Percutaneous drainage of leak fluid, sir.
Very
In
good.
the-
All right. Okay.
And is stent placement a minimally invasive procedure, sir? If it is
Excellent. What else? Yeah. Very good. You can have, what kind of stent would you use in a leak?
Covered stent.
It must be a covered stent. You have uncovered metallic stents. It's completely useless in a leak, right? You can use it to sort of make a passage through a tumor. But if you have a leak, it must be covered. There will be a silastic cover on your stent, and so there is no leak through that. So you have covered stent is one. Anything else? Endoscopic? If it's a very small hole, you can actually inject submucosally a bit of cyanoacrylate glue, and that closes the hole. Okay, I had a patient with an esophagocolic anastomosis. We had done a bypass for stricture of the corrosive stricture, and there was a very small hole in that anastomosis. So I could easily give an injection. It swells up the mucosa. It's like cement, cyanoacrylate glue, and that closed the hole, and the problem was solved. Anything else can be done endoscopically? You can put clips. Okay, so it's for you to know that you have endoscopic methods like clips and covered stents, injection of glue, which you can use to stop the leaks from small leaks. You cannot use it with very large leaks, because large leaks will also have a lot of soiling, a lot of septic load, and so the patient will be ill, and you will then be forced to do something invasive. Vacuum therapy, I have no experience of this, but it is coming into vogue in the recent past through even bigger leaks. Okay. If the patient is not in organ failure, you can put a sponge endoscopically. They say it's an extension of our vacuum therapy for skin wounds, which has now been extended to an anastomotic leak as well. And they claim, the papers claim 80 to 85% success rate in this, which I thought was remarkably high, but it is still something which has not come into routine clinical practice. But as I said, yeah, somebody's Nikita Reddy sponge. Yeah, that is the vacuum sponge thing that I mentioned about. You're right. What are the choices at surgery? Abdul, you've been very quiet today. So your patient is ill, is going into organ failure, you've decided to do a laparotomy. You can do a laparoscopy and see, but let's say you've decided to do a laparotomy. What are the choices that you have?
When the patient is ill, nutrition status might be affected. To better do a divergence.
So, no, it depends. It depends on the degree of leak and all that.
Yes, sir.
So it's not diversion straight away. Okay. So
Yes, sir.
you open. What are the scenarios that you can encounter? Just think of all the possibilities.
Sir, abscess around the.
Okay. You have an abscess. You
Fecal
drain the
contamination.
abscess. Okay.
Fecal contamination.
Fecal contamination. So what do you do after that? You find that there is fecal contamination and sepsis. You have drained, and an abscess. You drain that, but you don't have a major leak that you can actually see. The anastomosis otherwise looks intact. So what would you do?
Just put that remnant sutures around it, and
you don't see a leak. What would you suture?
you don't see that. Okay, sir.
Okay.
Just drain it and come out.
Drain it and come out. But if you're not too sure about the adequacy of that, you can give a proximal diverting stoma.
Yes, sir.
Okay. With a drain and give a proximal stoma. And then you have a small hole and you think it is healthy enough, use suturing. Okay, but
Yes.
never just use suture and come back. Always give a proximal stoma. Very
Okay,
important. Okay, never trust your suture, even though it looks good on the table. You may find that may not heal very well. So always give a proximal stoma. Even drainage, there is nothing to suture, but it's always safer to give a proximal stoma and come out, because after all, the patient, you have opened the patient because the patient was very ill. Okay, so that proximal stoma, I think, is something that we should always do. And if there is a big dehiscence, large area that is gone, what would you do?
Sir, resect it and.
No need to resect. It is
Like
just
in the
that the
sense-
anastomosis has fallen apart.
Do a divergence, exteriorization.
Exteriorization. So what are the choices in exteriorization that you have?
End colostomy.
One will be an end colostomy. Okay.
T-tube.
T-tube is not an option because the bowel is inside the peritoneal cavity at that time. Both the exteriorization has to come out. Okay.
Small bowel, sir, T-tube? No.
No, when there is an anastomotic breakdown, you really can't put a T-tube. Okay. So it's always better to exteriorize, because we're looking at a situation where you cannot suture because you think it's very soiled and there is a big possibility of it breaking down. And so you bring it out. You can bring it out as a double barrel colostomy or an ileostomy next to each other. Or you can do what is this, what I've shown here. A very unusual case where I had to do an ileostomy in the left iliac fossa. Okay, because the sepsis and the thing had made it so swollen and so rigid that I couldn't bring the ileum onto the right iliac fossa. So this is a mucus fistula. The non-business end of the bowel is brought out either as a separate lateral mucus fistula, or you can even bring it out in the wound. This is a midline wound mucus fistula, and this is the functioning ileostomy. That is also possible, but if you have enough length and supple bowel, you can bring them out as a double-barreled. Both the ends can be brought out in the same stoma. And if you think that in an anterior resection, for example, in a low rectum, where you cannot bring the bowel out, okay, it doesn't reach the skin, then you can stitch up the bowel and leave a drain and come out in the form of a Hartmann's procedure. That is also a very plausible thing that you do. So again, this is an area where you decide on the table as to what you need to be done, and these are the three options that are available. Okay, anything else, Ravi, Niranjan, Nishant?
Nothing, sir.
Nothing at all. So it's
So I
not.
think
Yes,
the
go on.
student should remember that the patient is in a much worse state now compared to when you did the anastomosis, whatever, 5 to 7 days, 10 days ago. Then they will be septic. There will be, however hard you tried nutritionally, they will be down. And so your surgical technique alone is not something that you should trust and say, I will re-anastomose. So do not attempt to do resuturing, as sir said. If you have done resuturing of the anastomosis, if everything looks healthy, you still give a proximal stoma. So it's very important, because not just your technique, because you have to look at the condition of the patient. The fact that you have actually decided to take him back to the OT means he comes on the fourth or the fifth category of the leak, anastomotic leak. From others, you would have managed them conservatively or quasi conservatively. So this last group of patients are obviously sick. So you have to give enough credence to that.
Yeah. So as a surgeon, it's not enough if you just focus on the anastomosis and its breakdown proper, but you need to have certain other things in your consideration. Remember, this patient is ill, as Ravi has been saying. Patient, is probably not going to heal very well. He's nutritionally down. So what are the other things that you can think of? Sanya?
FJ.
Okay, think of a laparostomy. You may not be able to close. You don't want an abdominal compartment syndrome. The bowel will be swollen. Okay, you do a laparostomy and probably go back in 48 hours later and then effect the closure. And I had given you a hint and Ravi had answered. Okay, always put a feeding jejunostomy in. Very important. Okay, most of it applies to distal small bowel or large bowel anastomotic leak. If you have a proximal bowel leak, you can put a feeding jejunostomy distal to your anastomosis and then start feeding. But again, remember, the best and the cheapest way to feed somebody is into the gut. Use it and make it available for use as much as possible without going into TPN straight away. There will be situations when you cannot use the bowel, in which case you can always go in for TPN. Okay. And what are the post-operative care challenges you will get? Sanya, just a few, list a few.
Nutrition, sir, nutrition,
Yes.
electrolyte imbalances.
Yes, good. Sepsis is the first one. There's a leak. Yeah. Wound infection. Okay. Intra-abdominal infection. Generalized sepsis. Organ, space, deep space infection, wound infection. Persistent collections can occur in spite of your best efforts. You can still have a collection. And in spite of everything, in spite of a diverting stoma, you will then have to look at draining it again. You can get fistulas again. Okay, in spite of what you have done, you may get a fistula. From a generalized peritonitis and intra-abdominal collection, it may become a localized fistula. And the general condition, apart from the abdomen, these are the things that I have listed in the abdomen. Without that, what else can you get? Skin issues, DVT, pneumonia, okay, and
UTI.
bed sores if the patient is in bed for a long time. So those are all, this is a big challenge. It's not something that is small. And don't think that just because you've done a laparotomy and exterior the bowel, the challenge is over. This is just the beginning, and you have a whole lot of issues that you have to attend to. Okay. We mentioned nutritional issues that has to be attended to. Any other comments? This is my last slide. Vinod, so you are having this ill patient with a leak, you've done some things. How do you know the patient is improving clinically?
Vital.
His nutritional intake is increasing and fever and episodes are decreasing.
Okay, becoming afebrile,
Tachycardia and vitals are improving.
Reducing inotrope support, reducing respiratory support. If the patient is on a ventilator, he can be weaned off. If he is on oxygen, even without oxygen, his oxygenation is maintained. Inotrope is not required to maintain his pressure. His moving his bowels are improving ileus. He feels hungry, he wants to eat. To me, this is one of the earliest and the best indicators of sepsis. Okay, you find that you give him, he's in a 4-liter positive fluid balance. Okay, still the urine output is 800 ml a day. You give him 5 liters of fluid a day. On day 3 or 4, when he is improving, this guy puts out 3 liters of urine straight away. So it's one of the earliest and the best indicators that his sepsis is improving. Okay, and improving demeanor. I mentioned it, Ravi mentioned it. If the guy is looking ill with you standing at the end of the bed, be careful, there's something going on. Don't underestimate that look. Whereas when he's improving, he's more cheerful, he's less sick looking, and that is quite important. Okay, thank you very much. And I'm open to questions. I hope you found this useful. Open to questions and comments.
One question I have.
Yeah.
Sir, FJ that you said, I didn't quite get it, sir. Which cases do you do FJ, sir?
Say that again.
Sir, in which cases will you do this FJ? You mentioned something. I lost my connection. I didn't understand that part.
Yeah. You mean feeding jejunostomy?
Yes, sir. Yes, sir. Feeding
Yeah.
jejunostomy.
You know, in any patient who's ill and who has a nutritionally depleted status in the preoperative phase, it may be,
Okay,
you know, before I even started a resection for a cancer, for example, or after the patient has become ill and not had nutrition because of his sepsis and ileus in the post-op phase.
yes, sir.
And perhaps I have just done a suturing of an anastomosis, of a small break in the anastomosis with a diverting stoma proximally. In any of the, or if it's a pancreatic leak, for example,
Yes,
okay,
sir.
after Whipple's, any of these cases where I find that the patient is not going to bounce back and be eating well in the next 3 to 4 days,
Yes.
I'm very, very liberal with a feeding jejunostomy. I just put a feeding jejunostomy. It may be an overkill, but I'm not dependent on TPN, and I'm not dependent on on the financial status of the patient. I can feed the patient up well. So I'm very
So, but
liberal.
even with the diversion stoma, you do a FJ with the contents coming out through stoma.
Yes. The reason is that the patient may not eat well.
Okay.
Yeah, and that, of course, if the patient is very well nourished, and I know that he's a very cooperative patient, if I've given him a diverting stoma where I'm not worried about a leak, I will not put a GJ, a feeding jejunostomy. I'll ask him to eat, I know. But if we're dealing with a very ill patient, and I find that patient is unlikely to eat well soon, I'm very liberal with feeding jejunostomy. Ravi.
Okay.
I think this is for the postgraduates. When you go in the second time, and as we said, we are going to give a stoma and a feeding jejunostomy. You have to be extremely careful in constructing the stoma, extremely careful in making the feeding jejunostomy, because you should understand the patient is not well, patient is sick and nutritionally challenged. So you don't want to have complications related to the procedures that you have done to improve the condition of the patient. So you have to take a lot of care in, not just leave it to your registrar and say, okay, you do it and go. You have to be there in when you second laparotomy, you have to be there till the end. I know it's good that your registrar can do it, but ensure that you are there and ensure that it is done properly. It's very important, I feel.
Nishant has a question which I missed. The gaps between sutures during surgery, which we check with an air leak and then close, is that an anastomotic leak? No, because you're still not completed the operation. You have found a gap in your sutures. You have closed it, and then after closing everything, after doing a repeat leak test and making sure that there is no leak, if it leaks in the post-op phase, that is an anastomotic leak. Okay. So I think I've seen all the questions also and comments.
Sir, if I can come in, sir.
Yeah.
Just one comment for Sania's question regarding that stoma and feeding jejunostomy.
Yeah.
I think as a not, of course, everything has to be patient specific, but feeding jejunostomy normally we do, it is distal to the site of anastomotic leak.
No, not.
If at all, like if it's
No,
a
no.
proximal, something is happening, like if you have
Not
done an
at all.
anastomotic,
That
need
is
not be a
where I got
leak.
confused, sir.
No. I'm
And
sorry. No, it's not distal. You see, suppose a patient has a big leak from an anterior resection. Okay. Patient
Yes,
is very ill. You have exteriorized the valve.
Okay, sir.
Okay. So there is no anastomosis. It's all exteriorized. But
Correct.
if
So
you,
in such a scenario, we don't need an FJ. We can directly feed the patient.
this is the point I'm making.
No,
If you're
no, Nishant, if the patient is very ill and if he's ventilator or if he's not able to eat, then FJ will definitely help rather than Riles tube.
That is the point. You understand? If the patient is still ill and you feel that, if I feel that he's not going to eat well, meeting at least
Next 10 days.
60-70% of
Rather
your
than
nutrition.
TPN, it is always better to feed enterally.
That is the point. Yeah, correct.
Okay.
Yeah.
If at all we are planning to do a diversion ileostomy, not colostomy, still FG is going to help, sir?
Yes, whatever, it depends on the condition of the patient. If the patient is not going to eat well in your assessment, because of his sepsis, because of his general demeanor, it may even be depression. Okay, you have seen this patient over a few days before you have done the re-laparotomy, you see, and you feel that he is not a cooperative patient who doesn't eat. It's always good to have a feeding jejunostomy.
Okay, so only the absorption part will be happening from the small intestine that is going to provide him nutrition.
Absolutely, always the case. Always the case. No, because large bowel absorbs only water.
Yes, sir.
Yeah. So,
Sanya, feeding jejunostomy can be a lifesaver or a life insurance. Either way, it is good.
Yes.
It can be an insurance policy. If the patient is eating, you have it as a backup, and and then take it out when the patient you are happy with his nutritional status.
Yes.
All right.
Thank you, sir.
Okay. Closing comments, Niranjan.
Sir, nothing, sir. It was very good.
Yeah. Ravi.
All aspects of anastomosis, the factors influencing good anastomosis, all of those things were covered. I think you guys have to go back and read up again. I think excellent, session for all of us.
Thank you very much, and good night to all of you. If you need, the whole thing that I said is completely evidence-based, and if you need papers or something like that specifically, it's for the registrars. I don't think our postgraduates need to read very much more than what we have discussed here. But if the registrars are interested and you want to read some more, I'll give you those references. Ask me at a personal level, and I'll send you those references. Okay, thank you and good night.
Good night, sir.
Thank you.
Yeah.
Good night, sir.